My name is Joshua Gibson, and you are listening to the Philosophical Weightlifting Podcast, a show dedicated to promoting a message of critical thinking as it pertains to strength training, nutrition, and well-being. This is done through interviews with experts, high-level athletes, coaches, and people heavily involved in strength sports and athletic development. Pull up a chair, grab a coffee, and let's get on to today's podcast. Hello and welcome to this week's episode of the Philosophical Weightlifting Podcast. I'm your host, Joshua Gibson, and I'm joined today by a person. We kind of did some looking into this beforehand. I haven't spoken to in nearly 5 years. That is Michael Ray. It's been a long time, and we of course we kind of caught up beforehand, but for the people who are listening who are like, oh, I remember those few episodes from Weightlifting House and then from the Philosophical Weightlifting Podcast that were really insightful and really interesting and deep dove on pain science and rehab, and they're listening to your voice for the first time in 5 years. What do you have to say to them?
I'm glad we're all still here. We are on the other side of COVID, which is nice.
Yeah, and I'm really excited for this podcast, and I think that allowing you a little space to kind of talk about where you're at, what you've been up to, what you're doing. You mentioned, kind of really getting involved with the research process and putting out quite a bit of work, and then looking to kind of become even more involved. What does your day-to-day look like currently?
It's a good question. Currently, I'm about to be on summer break, so a lot less busy. I've been currently giving final exams. So I gave my last final yesterday, and then I spent the rest of the day just grading. It's kind of a mad dash to getting finals submitted, and then we have graduation this upcoming Saturday.
Wow.
So yeah, I'll be attending that, and then I'll have a couple other service duties to the college for probably the next 2 or 3 weeks, and then I'm going on vacation because I need it. But outside of that, it's usually a mix of stuff. So I'm usually because I'm a tenure track assistant professor for a local college here in Virginia. And so I'm usually teaching a 4-3 load, so 4 classes in the fall semester or spring, and then 3 in the other semester. And it usually translates to teaching probably 2 classes a day, Monday through Friday. And those can be a variety of topics. Some of my favorites, I teach research methodology for undergraduates, health and fitness assessment, and strength and conditioning, introduction to nutrition, sports nutrition, probably forgetting something, introduction to health and exercise science. And so those kind of rotate. The core that I teach pretty regularly each year are the research methods, health and fitness assessment, sports nutrition, and strength and conditioning. Mm-hmm. And then I do pain research. So I'm still active in that, which has taken several different lines of investigation into the pain phenomenon. I've had a publication last year with a few dear friends of mine and also colleagues and very intelligent humans on the theoretical underpinnings of our models for chronic pain. So like taking a different approach, expanding beyond the biopsychosocial approach. So that would be much more of a theoretical publication. I've done qualitative investigation into beliefs about chronic pain, both on the patient side of things as well as the clinician trying to help the patient. I've done quantitative analyses, taking an epidemiological approach related to physical activity and pain. And then one most recent investigation, we were lacking data on the relationship between chronic pain and mortality rate. And so that's currently under revision with the Journal of Pain. Fingers crossed that'll get accepted. And then I do telehealth on the side. I run and operate my company Tame, Tame, Pain, and I do remote consultations for folks around the world that are struggling with chronic pain.
Wow. I would, I don't know how many people listening currently have followed kind of the arc of, pain science being brought a bit more to the forefront, and then discussed more openly, and then becoming, I mean, I say that as though I'm speaking for the public at large. I'm speaking for like the niche, strength sport, powerlifting, weightlifting worlds. But it kind of became a thing that was discussed, and rehab kind of became a little bit more discussed. And I feel like there's this like, um, bringing awareness to, maybe what it is a little more so and what it isn't a little more so. And I feel like you were part of that, and just bringing some awareness to a lot of the information coming out around pain science, like the research being published, different models. I mean, the fact that you can say biopsychosocial model, and I think I have an understanding of what that is. It's largely chalked up to, you and other people in this space. What's it been like, from your own experience being a part of that, kind of like bringing into public awareness? And then how have your views on the complexity of it all changed over time, getting more into the research, but also conducting the research and trying to answer the questions? Where do you kind of currently stand with how you think about how we conceptualize and understand pain? And I know that's not an easy question, but I'm just trying to get a sense of what this arc looks like. The mission of Weightlifting House is to bring the sport of weightlifting closer to the coaches, fans, and athletes. They're able to do this by supporting the Philosophical Weightlifting podcast. You can use the code PHILWL, that's PHILWL, at the USA Weightlifting House store. That will save you 10% off all products, including bars, straps, wraps, singlets, and anything else you could imagine. That is PHILWL, PHILWL, to save 10% off everything at the Weightlifting House store. And by supporting the podcast, you support Weightlifting House.
Yeah, I think those are great questions. As far as being a part of what I think is a bit of a movement, which was much needed, especially in the exercise science, health and fitness, strength and conditioning space with better understanding of pain. I think that's been awesome. I think that a lot of people have been taking up new perspectives, and they've found those perspectives beneficial for their own experiences of pain and how to respond to them. So when I zoom in at that level, it makes me happy to see that, and appreciative to have the opportunity to be a part of it. As I zoom out away from that space, I see we still have a lot more work to do. We're still seeing, there was a podcast released yesterday by a very high level individual with a very large following on low back pain stuff. And it was just the little bit that I did listen to, and from others that I heard from, it was not great information. And the work I do with Tame Pain, working with individuals throughout the world for chronic pain, leads me to hear stories that are upsetting, and from just a human empathetic perspective, like it's hard to listen to sometimes, because you can see the misinformation that spread and how it led to unnecessary interventions, and oftentimes unnecessary interventions that folks forget have risks, and those risks can be very real when they translate to outcomes. And so from that perspective, it is disheartening, but also encouraging from the sense of like to keep doing the research work that my team and I are doing.
Yeah, I don't think it's a stretch to say that you can, much like someone, becoming really understanding of the role of, physical activity, and the importance of physical activity and physical health, and prioritizing that, like, you really can alter someone's life by, changing their perspective of what something is. And I kind of, my undergraduate degree, there were a lot of narratives around, it kind of feels outdated at this point, but like adhesions and all these like different modalities to help fix them, and all this like really weird stuff that they called magic, and having that updated to where I feel so unreliant on anything but the training itself, and the management of like the training process for anything that comes up. It just it feels good. Like I tend to be relatively like minimalist anyway, so just saying like if something doesn't feel great, I can modify training, and like as long as I can keep training and keep doing something and stay active, like that's the thing that matters. And I felt that way for the last 5 6 7 years because of the information that's come out. And yeah, it's life changing, and then to also to be able to help people who might be kind of worried that they're experiencing something that's could be serious, and you just modify training and manage training in a way that allows for it to kind of like course correct. That's awesome. Like it's awesome to be able to do that as like a strength coach, but also to not like see people kind of like drop off and say, well, I can't lift now, like I've been told not to lift weights, or I could more seriously injure something. So I think what you've done and what you continue to do is incredibly valuable. And so I just wanted to say that. Where are your interests currently? And I know you kind of talked a bit about some of the publications you've pushed and been a part of, but where are your interests? Like, what are the questions you really want to get closer to answering, and how are you planning on doing that?
Hey, what's up, weightlifters? Danny here, founder of Onyx Weightlifting Co., a leather accessories company specializing in weightlifting gear. In our shop, we make gear that doesn't get in the way of your performance because we understand that hitting lifts requires your full attention. Our straps, wrist wraps, and belts are designed to be comfortable and reliable, so all you need to do is make lifts. Thanks for listening to our friend Josh's podcast. You can continue to support him by visiting our online shop at onyxstraps.com and using his code PHILWL. That's PHILWL at checkout. See you on the platform.
Well, I appreciate the kind words and what you said about our work. As far as the questions that we have remaining, that's a good one. I get pulled in a lot of directions by my own doing, which is funny because of one of the people I work with regularly, Kyle Keller, and he's up at Buffalo Medical School. He's often telling me like, "Hey, let's just pick a path and go down it." I'm like, "I hear you," and I see myself, as I've talked to more folks that I look up to in the pain research field that are well established researchers, meaning like many dollars in NIH level funding. I see myself gravitating more towards dissemination, meaning like there are reasons that you can poll clinicians and they are aware of evidence-based guidelines for clinical practice related to pain scenarios, and that we're not following them. And so we need to figure out that disconnect. Like, how can we be aware of, and the way I think about it these days, honestly, is a lot like smoking cessation, right? Like for a long time, we've known like smoking isn't a great idea. Like that's an increased risk, a modifiable risk factor for particular health related outcomes, both comorbidities and early mortality. But just having that knowledge isn't sufficient in changing behavior. And that's kind of where I think a lot of my interest is leading me, is looking at, well, what is the blockade? What's the barrier to translation to clinical practice? Because we're having real harms in doing non-guideline concordant care, meaning that we're doing things that we shouldn't be doing in these cases. And so, like we had a recent publication just last month in musculoskeletal care journal where we looked at clinicians' beliefs about low back pain. And we asked 163 of them from different various titles, because I don't think this is restricted to titles. So it was MD, DO, PT, DC, AT, OT, Um, what do you believe to be the cause of low back pain? And another question was, why do you believe low back pain reoccurs or persists? Another question is, when would you want to order imaging for a case?
Mm.
Another question was, how would you manage these cases? And another question was, where did you learn about low back pain? And we saw a lot of things come out of this. Some of it was encouraging. There were responses aligning with a BPS, biopsychosocial understanding, but then there was strong anchoring still to biological causes with very like a smorgasbord of interventions being utilized, many of which were not guideline concordant care. And there was unnecessary imaging being rationalized, sometimes under the guise of just, I'm paid based off of patient satisfaction. And so there were things in which, for that came out, it was like, okay, we're seeing people citing choosing Wising guidelines for imaging, but then also we're seeing people say, yeah, I'm aware, but I need to do this for job satisfaction. Outside of that, we also still saw like pretty significant patient blaming, which makes me sad,
Mm.
and aligns with like what we tend to specifically see in our culture. I think of you know why are we dealing with obesity? Well, you should just eat less and move more.
Yeah.
And we're not zooming out to say, well, what's the society like? What's the environment like? What are the affordances to the individual to be physically active, to make particular food choices? And so I'm seeing parallels. My master's is in exercise science, where I learned about that stuff, and now as a clinician doing research on pain, I'm seeing a parallel to that of, well, you weren't physically active enough, or you were too physically active, or you didn't do these exercises, or
Mhm.
you're dealing with overweight and obesity, or you're not managing your stressors. And I'm just like, damn, like, how do we get people to zoom out a little bit and say, hey, just because this person's reporting an experience doesn't mean they're solely
Mm.
responsible for the experience.
I mean, there's so much to comment on, and um, I would push people to listen to or I say listen to, because that's what I'm doing lately. But I would push people to read the book "Determined" by Robert Sapolsky, um, because I think it helps you get a clearer understanding of that point that you're making, basically, which is, why is something the way it is? Look at what occurred the minute before, the 3 months before, the years before, the thousands of years before. And you're like, oh, you're having to consider every context in which this situation occurred, which is every context that occurred before it, and all of the variables that construct the context itself, or the experiencer or experience itself. um it's incredibly complicated, which, from like an intellectual standpoint, is really cool to kind of think about and play around with. But practically, is like, it makes it really difficult to have conversations about, like, knowledge, right, or what we know, or why something has happened. Because, as I've kind of thought about with training theory, and this is where I would relate it to kind of draw parallels. Training is very complicated, and it can be written about in a way where it's like, oh, it's just, you do whatever, like, type of training, you drive this input, this stimulus, and then you get this adaptation. And it's like, I just don't know a world where that's as clear cut and straightforward, for many different reasons. I mean, maybe if our measuring, maybe if we had very precise measuring tools, we could better answer the question of, like, what adaptation occurred. And then you would think, okay, well, what are the mechanisms driving that adaptation? It's like, well, how would we measure that? How would we understand that? And then, it's like, okay, well, then what were the exact inputs that drove that adaptation? And then it's like, okay, well, how would you parse it, parse the training, um, to figure that out? And, it becomes very complicated, to where I think coaches rely just on patterns of, like, you do some type of training, you get a response, performance improved, therefore that's effective training, therefore we should do something similar, and we have best approximations of how we can get to more weight on the barbell or more weight on the scale or less, or, you know, whatever the adaptation is, or whatever the desired outcome is. And then we just, you know, assume adaptations that are leading to that. So I mean, what I hear is that it's very complicated. It's very complex. What could be happening is that people are told or taught certain narratives from certain evidence, or not. They're just kind of, you know, what seemed plausible, based on kind of like some information, and then that's like what they anchor to, and then it's like, how do we update those, and then how do we get best practices to align with what we understand about this like experience or this like phenomenon? Is that kind of what you're saying?
Yeah. And while you were talking, I was thinking about, you know, the fallacy of post hoc ergo propter hoc, meaning if this, then that. So A plus B must equal C. It's a causation fallacy, right? So like with periodized training, it's like, well, we did this and got this outcome, so that's why it happened.
Mm.
And then I think about John Kiley's work, who I'm a fan of, who's like, yeah, you know, it's great that we have all of this knowledge and information, and it's great we create this plan to get particular training adaptations, but we shouldn't, you know, and John, if you listen to this, feel free to like email me, like, you're totally wrong about my work. It's fine. But my interpretation is like, it's great to have a plan, but be flexible with the plan. And the plan, there is a risk to believe that you have more control than you actually do. And it's similar in clinical practice, right? Like, person presents with a numerical pain rating of X because we want to quantify things and objectify it, which isn't a discussion of good, bad. It just is. That's how our system functions. And so then we're like, well, we got to get that down. And if we get it down, then we get positive outcomes, patient satisfaction. And so we do these things, and we assume it's the things that we did in our clinical practice with the patient that led to the outcome we observed. And we know, like, that's just not. That is, by definition, the post hoc fallacy. We're making and drawing conclusions and then inferences, and we don't really have an understanding of other contributing factors. And I think a lot of us are. Like, I think one of the positive things social media does do is talk about things like the nocebo effect and placebo-like contextual effects. And there are more people questioning the outcomes we're getting. But I think, we're still in a place of, the way I think about this is, I'm trying not to make this too philosophical, which is funny because we're on the philosophical podcast. But I think about it like a bit like free will, right? Like, you're only as free as the options that are afforded to you. And we have differing options of affordances for a whole host of reasons in our society. Some of them very unfortunate that we continue to this day, which is marginalization. We're well aware of that. We even see health disparities in pain care, access to care, for example, and the quality and type of care you receive differing based off of geographical location and a whole other host of factors. And so I think there are particular policies and procedures that are in place that limit our affordances. The example I'll give are for chiropractors in the United States. And I haven't stayed up on this, so it could have changed in the past couple of years. But the last I looked, Medicare only reimburses for spinal manipulative treatment. So if you are having Medicare as your insurance and you go see someone in the United States and that's all they're paying for, then that's what you do.
Wow.
Because then it's pushed onto the chiropractor or the healthcare professional to say, well, I would like to do XYZ. Let's do behavioral changing, like motivational interviewing. Let's do some type of behavioral change intervention. Let's do physical activity even. You're not going to get directly paid for that. So then the cost gets pushed off to the patient out of pocket. And that's just one example in an outpatient setting in which the system is limiting our affordances to do the things that are likely more beneficial across the board for people dealing with chronic pain, much more holistic care. The things that we have evidence for are oftentimes not this perceived super specific intervention from a specialized care provider, but instead it's much more of a holistic approach. And I would still then challenge people to zoom out even more to our society level and kind of what we're seeing for people who are experiencing chronic pain and stigmatization and so on and so forth. So yeah, it's super fucking complicated. And I'm in there somewhere trying to just like help figure it out, of how we can do better in the future on this topic.
Yeah, I love that quote. You're only as free as your affordances. And I also like to, kind of deep dive into that concept of free will and play around with it intellectually. And I would like to understand why. So, okay, so we have this, we have this medical system, right? And we have all these practitioners, clinicians with such varying narratives around what's occurring, why it occurs, and then how to change its occurrence or to create a different outcome or manipulate the conditions by which a different outcome can occur. We can kind of set this up because I'd be interested in like filtering this question down ultimately to what your research would be looking at, which is like, how would you present information to change the understanding or narrative surrounding some experience or some information?
Yeah.
Why does it currently exist that we have such a discrepant understanding across, and this is, I mean, my brain goes a 1,000 different ways with this, but across the board with clinicians of the same experience or the same thing, basically, if we're using the same language, which is, pain. If you were to poll or ask clinicians about their understanding of pain, given that we all, basically would have access, I don't know if this is fair to say, but to the same information, why are there such discrepant understandings? And even adding a wrinkle of complexity to that, even when presented with the same information, like directly, like the same study, why would there be different interpretations to where it's like, well, my bias is further confirmed, and the alternative, which is the one you have, is further refuted with the same data?
Express the passion that defines you. At Virus, we understand that when it comes to performance, the slightest edge can mean the difference between winning and losing. Each product is designed and tested with performance in mind. This principle inspired the technology that is infused into our apparel. Built with the intention to move with you and work for you, we create tools meant to help express the passion that defines you. The future of technology-driven apparel. Improve performance, prevent fatigue, recover faster, and go further. Virus is a proud sponsor of Josh Gibson and the Philosophical Weightlifting Podcast. Use code PHILWL for 10% off at checkout. That's PHILWL, PHILWL, for 10% off.
Oh, there's a lot there. So let me start with the taking up different perspectives with differing titles, because I think it's a good question that I don't know I have the answer to, but I'll take a stab at it. Some of it is we live in a society in which we do prioritize titles, and that's a necessary component. It expedites the dissemination of information, while also on some level restricting that information to particular titles who have gone through necessary training. And on the whole, I think we do that quite well, right? So some of my research has transitioned me into the ED, looking at chronic pain cases presenting to emergency departments for a whole host of reasons, one of which these are often individuals who lack the affordances that a lot of us have, like regular healthcare insurance, regular health care, like a primary care physician, and is one of the greatest areas for potential misinformation or non-guideline concordant care, because EDs are trained very well at what they need to do, which is triage, stabilize, and discharge or refer. And where we get into trouble is that information that may be relayed by a particular title whose well trained, they're not trained on that particular topic. And what we're seeing with chronic pain is the vast majority of graduate healthcare education does not have a class on pain, doesn't have an elective on pain. For example, 80% of medical schools have no class on pain. And yet it's the number one reason people will seek healthcare consultation in the United States. And so it leads me to thinking like we probably need a few things to happen. Um, I don't think we're going to change all of the schools of thought on this. But what we could do potentially, and there are associations out there like the International Association for the Study of Pain, which has disseminated out course material like a curriculum with objectives and teaching points on updated information about chronic pain, that we could try to unify our knowledge. Because to your point, I don't think we all are operating off of the same information. I think it's very much hinged towards what's your school of thought. Are you a medical physician who's undergoing medical training? And in the pain field, a lot of times that looks like an interventionalist, meaning what can we do to you to fix you? Works quite well in a lot of scenarios, most especially like I often think of COVID-19, right? We saw a novel infection that took the world by surprise. We were having patient symptoms that were unexplainable. We isolated it. We figured out what was the biological link, the virus, and then we synthesized a vaccine and treatment protocols. Works really well in those scenarios. If you read Jacob Staganga's work on medical nihilism, he talks about it as silver bullets. We can directly intervene on the etiology of a disease. Chronic pain is not that. And for a long-standing time, that's how we've approached it. And so DO school would be similar to MD with a little more of my understanding as a holistic approach. And that's just my superficial understanding of their training. Feel free to correct me for listeners. And then we're seeing DCs, chiropractors like myself, are trained a particular way, looking at it from a bony structure or misalignment or nervous system issue. You see physical therapists looking at it in another way who have taken on some of the perspectives of chiropractors with joint manipulation. You see it from an exercise standpoint for them as well, and then also from a passive modality. And those two fields have kind of crossed a lot with, they're both from a scope of practice standpoint and from a billing standpoint, capable of doing a lot of the same things. So like therapeutic exercise or ultrasound or dry needling or e-stem or kinesiotape. And so you see kind of these silos of information and approaches to the same phenomenon, which becomes ingrained in people on top of licensure and scope of practice, on top of continuing education. And so I don't think we're all operating off of the same information, albeit I think it's getting better because of social media. It's one of the positives. I think we still need a unifying either title or certification or class on the same approaches with chronic pain. And then I don't think that would be enough, right? Because that's more going to be a little bit of mid-level top down, but we still have to go a next level up to system level, to policies and procedures, which is going to be much more at the governmental level and state level for scope of practice, for billing, what's allowed for billing, from diagnostic codes. So ICD-11 codes actually have chronic pain diagnoses. That's going to make a difference for reimbursement for diagnostic care as well as for management. And so those things have to be put in place. And then also we still need bottom up. So approaching it from general population knowledge and beliefs before entering into the healthcare system. Once they're in the healthcare system, patient beliefs as well at that point. And so I kind of view it as a top-down, bottom-up approach. So that, I think that answers part of your question.
Yeah, that was great. I mean, I think it provides a ton of context, and obviously we could get, we could then kind of shift to a question of, well, who decides, the information to disseminate, right?
Yeah.
Like who then would decide, well, this is what would be deemed correct. instead of that, you kind of round it off with talking about, at some point having the patient better understand, X thing beforehand. And coming from a space where, I had a policy and advocacy class this like spring semester, and it was my first introduction to policy kind of at all, honestly.
Yeah.
Um, and then this idea of looking at different policies, um, it's kind of like having some sort of discussion around how does that policy actually influence people in the field? How do they actually change their practice or what they do? And what I would wonder is if you have information and some sort of data on um, the pain experience and best practices, or and maybe in my case like physical activity and the importance of and the role of, and then how we can help people become more active. I live in a place where there are like no sidewalks. There's not, people really aren't like outside walking around. There's not really a place to do it. Whereas, prior to this, I lived in the Bay Area and I lived in Berkeley, California. And it's like, that's the thing. Like that's the most important thing there outside were the pedestrians, and like the bike paths and all of the sidewalks, and kind of having that all embedded into the landscape, like having opportunities to be outside embedded into the landscape. How do you conceptualize the process of educating the public and then creating policy that supports what you've then educated them on? To say, well, this is the importance of physical activity, but you don't have access to a space, is different than this is the importance of physical activity. You have access to a space, but then you still don't want to use it. How do you merge those two to where we can change policy and then also bring education to a point where we can instill, the most up-to-date information about the importance of physical activity and the place and role of it within someone's lifestyle, or in your case, but also in your case, this understanding of pain, and kind of updating their understanding and belief surrounding it, and then how they act on that information.
Yeah. So I think from a general population pre-healthcare system, there should be educational campaigns reaching the broader public. And we see some of that, right, for other modifiable risk factors related to physical activity, related to smoking cessation, related to STI, for example. So we already do public outreach in this regard. I mean, we saw it dramatically with COVID-19. And so I see it similar from a pain education standpoint of educating the population before they ever get into the healthcare system about pain and the complexities and the meaning thereof and what it means from a physical activity standpoint specifically. Because usually what you'll find is it's almost people are dealing with a bit of cognitive dissonance. And I often blame us healthcare professionals because on one hand, they're like, yeah, I know I should be physically active. And on the other hand, it's like, but I have pain in my knee and I'm worried about, the doctor told me that I have pain in my knee because of osteoarthritis. And that's because the joint's wearing out. And that's because I overutilized it. And so I don't want to use it, but I know I need to use it. So I don't understand what should I do? And they feel stuck. So I think if we could educate before they even get into the healthcare system, that would minimize a little bit of what we're seeing of misinformation in the healthcare system. And to be completely clear, I don't think that's malicious intent or nefarious or anything. I think it's just we are not preparing healthcare professionals to manage these cases once they make it into clinic yet. So we should probably be educating before the people get into clinic. And then that way, they understand that, yes, it's okay they're having some knee pain, but they can still also be physically active because the broader benefits of physical activity far outweigh any perceived risks for that knee and for them. And more importantly, that just because we're having pain in an area, it doesn't mean that we're damaging, harming, or hurting ourselves, and thus we need to avoid. It's much more of how can we auto-regulate our activity based on our experience, with a new understanding that we have pains at times, aches and pains, and that's part of being human. And it isn't directly indicative of body state or damage or harm that's happened at the area. So, with that new understanding, I think it would lead to more people wanting to engage physical activity. With the understanding that I'm purposeful in my language, that I'm not saying exercise, saying physical activity, which is any bodily movement that increases energy expenditure. And so that could be just like doing activities of daily living. That could be just going for leisure walks. It doesn't have to be I went to the gym and loaded my knee and barbell back squats. Cool, if you want to do that. We know that fitness adaptations only improve upon mitigating early mortality and the development of comorbidities. But that initial step, especially when you only see 24% of the population engaging physical activity, to me, the initial step is, can we just keep them moving more and moving more with a better understanding of pain experiences? And I think part of that is going to need to be, we're going to have to intervene at the healthcare professional level, because at some point when you have pain, you're worried. Like, that's a normal response, is like, what does this mean? And so they're going to seek out care. So we need to be able to educate healthcare professionals that disseminate out the information. And this has been a major talking point. I recently wrote, and I talked to you about this before we got on the call, or started recording. I recently wrote an NIH grant, an R61, for intervening at the ED level for people seeking care for chronic pain. And so it's been a big discussion amongst my team members and I, of like how to approach this. And so it's like, well, what do people need to know? What should our healthcare professionals be telling them? Is there something that we could do at the point of contact of consultation? Can we give them a script to tell, like, this is what you need to say to the patients? Obviously, say it in your own way. And so that's what we're trying to figure out now, is like, what is the minimal effective dose for information to relay to people, while also minimizing harm to them by doing unnecessary imaging, unnecessary medication prescriptions like opioids for certain cases, unnecessary injections, unnecessary specialty referrals for surgery, and so on and so forth. So it's that's what we're trying to figure out, that we don't have the answer to at this time. Hopefully that somewhat answers your question.
No, it completely does. And for this specific episode, a little short on time, so I think we're gonna wrap up here. And I'm saying that because I think this sets us up perfectly for the next one, where we can talk about all of the information we have or knowledge we have. Where did that come from? So, like, all of the science or research, basically, that was conducted or is being conducted or is in the process of being kind of written up to be conducted in the future. What does that process look like, and how can we best use that information given the limitations that it could have? So, like, all the information we have that basically would say, this is why you would do one thing over another, because I have this like evidence-based whatever supporting me, this like body of literature. It's like, well, what is the body of literature that people refer to? What is science? So I think we're going to get a little more meta with it.
That'd be good. I think we need a philosophy of science discussion for these topics, for sure. I'm a fan.
Awesome. I agree entirely. And before we're able to get to that, if people are interested in checking out your work and kind of getting up to speed on what you've done, if they haven't checked it out prior, where can they do that?
Yeah, you can go to my website, just tamepain.com. I'm also very active on Instagram, as well as Twitter, or X, which I still can't stand calling it that. And for that information, allow me to look up my handle, because I actually don't remember.
Oh, sure.
Michael_Tame_pain for Instagram. And then for Twitter, It is Michael Tame, all one word. Those are probably the two platforms I'm most active on, that I put out information pretty regularly.
Awesome. I'd highly implore people to go check that out. If you want to follow me, you know where I'm at. Josh_Phil WL. That's PHILWL on Instagram. Thanks again for listening to another episode of the Philosophical Weightlifting Podcast, and we will catch you all next time.